rectal cancer treatment, it's Dr. Habr-Gama. So we are very glad that she will give her presentation on how to avoid surgery in rectal cancer. Please, Dr. Habr-Gama.
I am very honored for this invitation to come to talk about a very controversial issue. Thank you. I am very glad to have both colleagues for our coordinators. Good morning for everybody. It is really a very difficult subject to talk about because it is very controversial. But to do anything different, we have to have a very good team. And fortunately, I have a very good team. Good surgeons, good oncologists, good radiotherapists, and good radiologists, and good nurses, and they have a very good team, and I'm very grateful for them for all the help they give us. Certainly, surgery, well done, as Dr. Glinton mentioned, well done, very good surgery, TME. It is the best treatment for rectal cancer. But unfortunately, even performing a very good surgery, we have recurrence. And this is why surgeons and oncologists try to do something different. Nowadays, more and more, we use selective neoadjuvant chemotherapy, particularly for those cancer in the low part of the rectum, and for some in the middle and upper level when they are very aggressive children. But we're becoming more selective for doing, as was mentioned by Glinton, was mentioned for indicated radiochemotherapy. But we know the positive effects, very good effects of radiochemotherapy for rectal cancer, not only for downstaging of the tumor itself, but particularly for the lymph nodes, that it can also decrease the number and even in the number of metastatic lymph nodes. And doing chemoradiation for selective cases of advanced rectal tumor, and all my data mentions the low rectal tumors, we can achieve an extremely good response. You know, in the literature, even up more than 30% of complete pathological response. And if we can achieve more than 30% of pathological complete response, it is hard for surgeons sometimes doing large operations, surgical operations, and without finding no tumor cell in the surgical specimens, no tumor. It is very hard for us to do very aggressive surgery in patients without residual microscopic tumors. So we have to be at the place of our patients and consider the potential benefit of this kind of treatment by achieving complete pathological response. And the best for us, if we can have complete pathological response, we have to find a way to recognize response before surgery, because we think, as Gerard mentioned, and we think that chemotherapy is very important for achieving complete pathological response, and doing so for, in some cases, avoid radical surgery. We know the difficulties we have with the radical surgeries, and in Lisbon, Bill Hughes, Beats, and Carlos organized a very important meeting only on rectal cancer when do not operate. It was a very important meeting. And Bill Hughes, I think, one of the most famous surgeons of this era, mentioned that pathological complete response, what does it mean? Is it a triumph or a tragedy for the patients? we tell to the patients, you have a very good prognosis, probably you are going to be cured. But the patient himself or herself tell us, doctor, I am cured, but I don't have a very good quality of life. I have many problems, and problems are inherent to radical operations, low colorectal anastomosis and coloanal anastomosis after radiation therapy. We have most results concerning function results after chemoradiation. And we know the rates of complication, and not to mention the necessity of stomas, temporary, almost always status, or sometimes permanent stomas. It is a wonderful operation, but it must be used when there is no response to chemoradiation. But it is not easy to choose the way we go. The hard way, the easy way, and we mentioned Dr. Niagara, and we were inspired by Dr. Niagara, who was the first in the scientific world to call attention that anal canal cancer, most of them can disappear after good chemoradiation and without operation. And we know the evolution of surgery. We know Halsted was recognized the very radical surgery. Now, more and more, we are becoming less radical in surgery. But it is easy to mention, but we have many problems in not immediately operate patients after they have a very good response to chemoradiation. First of all, it is not a good, perfect definition of complete clinical response. It's not easy to assess response. We know that when a tumor disappears, maybe the patients may have a microscopic disease. And we know that keeping patients under observation, tumor may regrow. And then another case seems there's no many other trials even consider this is a very good approach. What is our definition of complete clinical response? We can mention here. We publish a paper, a multi-center paper, trying to uniformize what we consider a clinical complete response. Then we can, digital examination, which is very important, endoscopic, but even we need radio imaging confirmation of our response. We have to have negative radiological evidence of extrarectal disease. And for us, arbitrarily, we consider complete clinical response if it is sustained for at least 12 months. But we know, as I mentioned, the difficulty in assessing response. But response, it is a question of time. And the one first published paper regarding this subject was made in France, and Dr. Jahar is present, that the more we wait, the more we gain concerning response. And many other papers have been published. Now considering that a minimum of 7-8 weeks is necessary to make a good assessment of response. This was published by the Cleveland group. But the response is increasing week by week, but it stabilizes after 12 weeks in this paper. There's another paper, one trial that is running in London by Diana Tate, Gina Brown, and many others, trying to study the response after 6 weeks and 12 weeks, and we fortunately belong to this group who is performing this trial. How can we judge complete response? Clinical ways, endoscopic and imaging, as I mentioned. Digital examination, the bioprobe, it is extremely important because we can touch polyps, ulcerations, we can touch induration. It is absolutely imperative to do it frequently. Endoscope, it is very important, as I mentioned. Imaging, particularly MRI, and we use more and more PET-CT to confirm when we judge patients had a complete clinical response. Molecular biology, it helps not for detect complete pathological response now, but probably in the future, it started now, we can predict which patients will respond to chemoradiotherapy, or if the tumor is sensitive or not to the chemotherapy regimen. This is typical cases of, we mentioned that it is complete response, whitening of the mucus in the site where the tumor was, very important. Look just back to the whitening of the mucosa, and when we pass this, we see only this whitened area, and in some patients we can see also some telangiectasis. Now we can use some additives to make it easier to identify subcurrents, to identify the area when it was. And you can see telangiectasia that may remain in the patients even for years. But you don't see tumor, you see only the whitened area and the vascular system. And this is an example of a patient with remaining a small polyp at 7 weeks. We wait for 14 weeks, and the lesion was almost disappearing like here. And you can see here that this patient, as I mentioned, it is important to have imaging studies to confirm our complete clinical response. Ultrasound is good, but MRI, as was mentioned, it was more perfect, and it helped a lot us to study the extra disease, to see the nodules and to see the invasion of other structures. And even as Gina Brown mentioned, nowadays we can predict those patients who have favorable or unfavorable response. We may have unfavorable response to chemoradiation. Wonderful work, and this is the PET-CT that we have a published paper. We did a study paper performing PET-CT at baseline 6 weeks and 12 weeks later, and we can judge very well the response, the disappearance of the lesion, as in this case, even after 6 weeks. And our final result of accuracy rate of PET-CT was 85%. But what is the our protocol? In our hospital institution, we give selective treatment, and we consider the patient not before we choose the operation, the management, not before, but after assessment of response. And when some residual lesion on the tumor does not respond, we do very radical operation immediately. But when there is a small lesion, we can do surgery. But in these cases, as I mentioned, we can do local excision when some small lesion remains. But when the response is judged as completely, we put the patient under the watch and wait protocol. we use local excision only for the equivocal cases, not for always. We use it only when we see a residual lesion, because very often when we do endoscopy, we don't see anything. And as I repeat, that selection of our management must be made after complete reassessment. This is a case of residual lesion, very small. And in this particular case, we perform the TEM, a full thickness excision. With this, we can have a very good sample for pathological studies. And then, after this, we can judge if this resection was enough or not. We can do with this method a very good excision, complete excision of the suspected residual lesion. But this operation, it is followed by pain and a variable rate of complication. It's not an easy operation. But neoadjuvant treatment may lead us to have downstaging, and doing so, as I mentioned, to have organ preservation. TEM, local excision, may be used only for diagnostic purpose, and with some patients as therapeutic procedures as well. And you have to have a very good pathologist to study the specimen, and then our future management will depend in the classification of UTB-T1, T2, or eventually T3, or if there are some associated bad, high-risk features. So TEM is a good operation for some cases. But when the lesion disappears, what to do next? The lesion disappears, what to do? Radical surgeon, or be patient, calm, and follow the patients. And we follow the patients. And we follow the patients very, very carefully. Not only for 1 year, but we tell to the patients, we discuss to the patients that follow-up, it will be forever. The more they come for follow-up, the better it will be the results. And we assess the patients in the first year, every 2 or 3 months. And we do GICC examination endoscopy, but after 6 months, we do MRI. And in some cases, we also do PET-CT. And the spacing, the intervals of examinations will be more large, more longer after 1 year or 2 years. But we tell to the patients that whenever they have some suspect regrowth, we have to put them under operation. Local excision of the regrowth very small, or even radical operation. They must be aware that the not operation, immediate operation, is not forever, that they may undergo operation during the post-chemotherapy period. We are always very alert. We are ready to move our policy. Is this good, right, or bad decision? We know the criticism about this policy. Our good friend, Julio Garcia Aguilar, in the FICAR in 2011, he presented this slide. And he mentioned the same critics that many others, such as an oncologist, tell us. We are aware of these barriers, of these critics, but more and more, studying our patients and studying our results, we are becoming more and more convincing about the good results we are having. We published a paper comparing patients with clinical response who undergo an operation with another group with clinical complete response that we follow with watch and wait. And we had the same results for both groups, operated or observing these patients. And also, we were very much concerned. If you postpone operation, when we have to do the operation after for regrowth, if the interval of this operation, the long intervals, will harm, you jeopardize the patients. And we published that the interval for us, for the operation, didn't give any harm to our patients. So more and more, we are becoming convincing about this good policy of watch and wait after having a complete clinical response. And we know by many papers that results, prognosis of the patients depends not only of the stage when they present the disease, but particularly the way they respond to chemotherapy. When they respond with a complete pathological response, the results concerning disease-free survival are extremely good. So it is our aim to give to the patients a protocol that we can have a major number of pathological or clinical response. So nowadays, we changed our convention protocol. We increased a little bit the dose of radiation, but we changed the doses of chemotherapy, as I am going to show you. And as a result, we increased a little bit the time for reassessment. This is our first protocol that we use. We start in 1991, so we have more than 20 years of experience on watch and wait. We started in 1991. It is, and I published this paper in 1998 using the convention scheme, 2 cycles of chemotherapy during the period of radiation. And since the beginning, we waited 8 weeks for giving for the first reassessment. And our dose of chemotherapy, of radiotherapy, was 50.4 centigrades. And our drugs, we use 5-FU and the recovery. But more and more, we are changing to capecitabine because we think it is better more comfortable for patients, and we are having the same results. And you see, now we're changing the protocol. We increase the number of cycles of chemotherapy using the same drugs. Now, during the radiation period, we give 3 cycles of chemotherapy with the interval of 21 days. And during the resting periods that now we have to consider 9 weeks, we give 3 more cycles of chemotherapy. We call it this extended regimen, but now we can call it consolidation chemotherapy. And we published this paper. And interval now, certainly 9 weeks, we are doing the decision after 10 weeks if we need to operate the patient. We increase a little bit interval. And doing so, certainly, we are achieving, we are approximating, we are becoming more and more closer to NIGO's results. Now, with this new protocol, we increase the rate of clinical complete response from 27 to 57%. Only to mention that until 2011, we had this number of patients under this protocol. And you can see that 199 patients had initial complete response. But from these patients, 49 had early regrowth. It is regrowth. Problem was we were not completely right in judging complete clinical response. And from then, we know that one 150 patients sustained the response for 1 year. And of these patients, and between 20 of these patients with sustained complete response for 1 year also had a local recurrence. And until then, from this group, we had 130 patients who no radical surgery was required. And you can see, and we do operate these patients. Most of our patients undergo this protocol, undergo an operation. But 1/3% we can save them. It is very interesting that in recurrence, frequently they are endorectal, and we can see the recurrence if we endoscope these patients every 2 or 3 months. When we have recurrence, are they salvageable? We recently published the paper with this subject, and we can say, and you can see the recurrence, and for these patients, we perform a coloanostomosis, and even with sphincter saving operation. And what about in our patients, distant metastases? Were they much? I think we had recurrence in this group of patients, particular study for recurrence. And we had 14% of distant recurrence. But it is very interesting to compare the results with the results concerning pathological complete response and adjuvant chemotherapy that they had in this paper published by the group of Netherlands, Maas. They presented 11% of systemic distant recurrence. It's not very different. So we have to avoid surgery, and avoiding surgery, we have to do the modifications in our traditional protocol. Our recurrence, it is very important to talk about recurrence after this kind of management. But salvage is very important. It is our results concerning local recurrence. After this, we had 31%. And local recurrence after complete clinical result and watch and wait, we could salvage 93% of these patients. And most important, we had organ preservation in 8% of our patients. And local recurrence-free survival after watch and wait and salvage was 94%. Distant or systemic recurrence, certainly it is the main problem of the treatment of rectal cancer. We have to find new protocols of chemoradiation to improve our results concerning distant disease. But I have to tell you that our results concerning our final results concerning survival, they are extremely good. And you may see in this presentation that more than 50% of our patients, they have more than 5 years of follow-up. And you saw our overall survival rate and our disease-free survival for 5 years of 79%, and 10 years, 73%, with a mean follow-up of 7-8 months. But this protocol, it's not for all patients, and even not for all surgeons, because it is not so easy to do this. It is a sacrifice for both, but I think it is good to have it. Another criticism, there's no other trials, but we are very glad to know that nowadays the group from Netherlands, the group of England, the group of Memorial United States, in particular, I was very happy to see this published by Dr. Cunningham, mentioned in his new algorithm. that when patients have a complete response, they may put under observation, and he mentioned adjuvant chemotherapy. So more and more surgeons and oncologists are going to the same, sharing with us our opinion. But we have to do a very personalized medicine. This idea that rectal cancer may be cured, some of them, by radiotherapy or chemoradiotherapy, it's not mine, and it is not from Niagara's. It came from GICC, from England, many, many years ago, in 1935. But thank you very much. We have to change our opinions. The more and more surgeons are changing, and surgeons are thinking more as oncologists and physicians. Thank you very much. Thank you.